Welcome back to our series of seminars on epilepsy. Over the last week, we have reviewed the introductory session on epilepsy. At the end of session 1, do you understand the concept of the epilepsy treatment gap? Have you considered the biopsychosocial impact of epilepsy in your community? What is the stigma and what are the cultural beliefs and challenges in the health systems that you work in? Have you thought about the factors contributing to the epilepsy treatment gap in your setting? Can you define seizure and epilepsy, and do you know the difference? Do you understand the difference between an unprovoked and provoked seizure? Do you broadly understand when to diagnose epilepsy? Can you classify seizures by type, that is, generalized and focal seizures? There was a lot of information in session 1, but I assure you, as we progress through the sessions and apply this information to clinical scenarios that we actually work with, we will start to get a better understanding and grasp of the various aspects of epilepsy. Here we have a snapshot summary of session 1. Let's quickly review. In the yellow box, a seizure is the event. Epilepsy is the disease. In the pink box, a provoked seizure has an identifiable underlying medical cause, and an unprovoked seizure has no identifiable underlying cause. In the blue box, you see the clinical practical definition of epilepsy. A person can be diagnosed with epilepsy when they have at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure with a probability of further seizures occurring, or a diagnosis of an epilepsy syndrome. In the left upper hand corner, you see depicted a generalized seizure which affects the whole brain. And below it, you see a focal seizure which affects a specific part of the brain. And finally, on the white table, you see the ILAE, International League Against Epilepsy, classification of seizure types into focal onset, generalized onset, and unknown onset. Now, let's begin session 2. Pathophysiology and etiology of epilepsy. Pathophysiology describes the abnormal mechanisms in the brain that lead to a seizure, and etiology describes the underlying causes of seizures. Objectives. At the end of session 2, you will be able to describe the basic pathophysiology of a seizure, understand the underlying medical causes of seizures and epilepsy, Discuss other contributing and precipitating factors, and apply what you have learned to clinical scenarios. Normal physiology of the brain. As you know, our brain controls all of our bodily functions. The brain is made up of numerous nerve cells called neurons. The average brain has more than 85 billion neurons. They are most numerous in the brain and spinal cord, but there is also a network of collections of neurons called nerves throughout the body, which transmit information from the brain to the rest of the body and from the body back to the brain. Each of these neurons is an electrically excitable cell, and this is how it transmits information from the brain to the rest of the body through complex electrical and neurochemical signals. I'm once again going to compare the electrical activity of the brain to the electrical wiring in a house. Let's say the house is the body and the main junction box or fuse box is the brain. The wires connecting the fuse box to the rest of the house can be compared to the nerves connecting the brain to the rest of the body. The fuse box supplies electricity through the wires to every part of the house, which is how you can switch on the bathroom light, turn on the toaster in the kitchen, or the fan in the living room. Similarly, the signals transmitted from the brain via the nerves to the rest of the body enable us to speak, walk, and do all other activities. Now let's say one of the fuses in the fuse box malfunctions. This fuse box supplies the bedroom. It causes an electrical surge at one of the switchboards in the bedroom, causing an electrical fire. Think of this as a focal seizure. Malfunction of a specific part of the brain affecting a specific part of the body. If the bedroom light is still on, think of it as a focal seizure without loss of consciousness. But if the short circuit is so severe it shuts down the electricity to the bedroom and the light goes out, think of it as a focal seizure with loss of consciousness. In a separate scenario, think of all the fuses in the fuse box malfunctioning at once. All the lights in the house, in every room, start to flicker, and the electricity to the entire house is shut off and the house goes dark. Think of this as a generalized tonic-clonic seizure with loss of consciousness. The next question we can ask is what causes the malfunction to occur? What causes the fuse box to break down? What causes the seizure to begin? As we have discussed, the brain transmits signals through electrical activity as well as neurochemicals called neurotransmitters. The two main neurotransmitters in the brain are called GABA and glutamate. GABA is an inhibitory neurotransmitter and glutamate is an excitatory neurotransmitter. The more GABA there is, the more inhibited and sedated the brain becomes. The more glutamate there is, the more aroused and excited the brain becomes. in the normal brain, there is a delicate balance between these two. If you look at the picture to the right, in the middle, you see good balance, normal wakefulness, normal arousal, and sleep. There are external factors that can affect this, such as drinking coffee. As you know, coffee is a stimulant and makes us feel more awake. On the other hand, a medication like diazepam, which increases GABA and inhibition of the brain, can cause sleep and sedation. Now, when the brain is excited beyond its normal capacity, a seizure can occur. Think of it as a severe power surge that can result in a short circuit. When this excitation is prolonged and sustained, it can even result in death, such as in status epilepticus. To the left end of the spectrum, when sedation becomes severe and prolonged, it can result in coma or even death. As we discussed, an abnormality in the normal balance of these chemicals in the brain can result in a seizure. Today, we will be discussing some of the causes of seizures. It is worth noting that all of these causes, directly or indirectly, cause an imbalance in these neurochemicals, that is GABA and glutamate, resulting in excessive excitation of the brain, which could potentially lead to a seizure. The pathophysiology which we have reviewed so far may not directly impact our clinical care, but it is helpful to know this as it relates to how and when a seizure occurs, and we can also better understand the role of medications in the treatment of epilepsy. On this slide, you see a long list of causes for seizures. There is no need to memorize these different causes. We are simply reviewing them to familiarize ourselves with the numerous medical conditions that can lead to seizures. I will take you through them one by one, while highlighting the most common conditions that we see in our practice. First, we have metabolic causes, such as hypoglycemia or low blood glucose, hypocalcemia, other electrolyte imbalances, including sodium, potassium, and magnesium, hyperbilirubinemia or jaundice, which can occur in liver failure, and uremia that can occur in kidney failure. Next, we have infections. There are the intracranial infections or infections of the brain, such as meningitis, encephalitis, AIDS-related infections, and cerebral malaria. Then we have extracranial infections that can lead to fever, causing febrile convulsions. Next, we have trauma to the brain. Birth trauma that can occur during delivery, as well as head injury that can occur later in life. Next, we have anoxia, or lack of oxygen supply to the brain. This can happen due to birth asphyxia, where the baby's brain does not receive enough oxygen. This can lead to conditions like cerebral palsy as well as seizures. Next, we have toxic causes. such as alcohol and withdrawal from alcohol, as well as medications in toxic doses, and other poisons. To the right, we have space-occupying lesions, such as blood in the brain, an abscess or tumor, circulatory disturbances, such as stroke and other vascular abnormalities, cerebral edema or swelling of the brain that can happen with severe hypertension or head injury, congenital problems that occur from birth, such as malformations of the brain, like hydrocephalus and microcephaly, which we have seen in our practice. We have children presenting with abnormally large or small heads, typically with seizures, particularly to the PDC clinic. Then we have degenerative diseases, such as dementia. And finally, we have epilepsy, where the seizures occur without any underlying acute causes. We have reviewed several medical causes of seizures. As mental health providers, we are not necessarily expected to diagnose or treat these medical conditions. However, it is important for us to be aware of them, because seizures are common and treated in all branches of medicine. They occur in the emergency, in internal medicine, surgery, pediatrics, maternity, and even in mental health. Any person may develop a seizure in certain circumstances. It is important to find any underlying treatable cause. Many causes, such as metabolic or infectious, are easily treatable, and this must be done before giving anticonvulsant medications, which may not help or in some cases be even harmful. A good clinical history, physical exam, and investigations are vital to help find a cause. The better our investigation methods, the more likely we can find a cause. So what happens in a resource-limited setting where testing is not available? This is when a good clinical history and exam, high clinical suspicion, and appropriate referral to higher level of care is important. As we have discussed, a provoked seizure occurs due to an underlying medical cause, such as those that we've reviewed on the previous slide. When the acute medical condition that caused the seizure is cured, sometimes the brain may have been permanently injured or altered so as to give rise to spontaneous, unprovoked, recurrent seizures in the future. In such a case, epilepsy may be diagnosed. When the medical condition is treated appropriately, for example, if a person presents with severe hypoglycemia and seizure, and the hypoglycemia is immediately treated and blood sugars are well controlled, epilepsy will likely not follow. If a disease was severe and prolonged, not appropriately treated, this can result in lasting brain damage. Some diseases can injure the brain tissue and leaves scarring permanently on the brain. For example, imagine you have a cut on your hand that gets infected. You take antibiotics and the infection is cured. As the cut heals, it turns into a scar, permanently altering the skin around it. Similarly, this can happen with brain tissue as well. Any brain scarring or abnormal brain tissue can act as a focus for abnormal seizure activity long after the acute condition is healed. Other contributory and precipitating factors. First, genetic factors. Some patients may be more genetically predisposed to having seizures than others. Second, age and maturation of the brain may determine whether or not a person has seizures. And third, other precipitating factors. There are several external triggers that can lead to seizures. These triggers may be different for different individual patients. Some patients learn which of these factors are important for them and modify their behavior or activities to avoid seizures. Therefore, discussing this with patients while psychoeducating them can be very helpful. Some examples are flashing lights, hyperventilation, low alertness or lack of sleep, emotional distress, excessive physical stress, special smells, sounds, or sensations of touch, alcohol, hormonal changes, example during menstruation, high fever, or overhydration. As we discussed on the WhatsApp group, one of our colleagues asked the question about EEG. And I had mentioned that sleep deprivation can sometimes be used as a trigger to provoke epileptic activity when an EEG is being recorded. Some of these other triggers, such as hyperventilation and flashing lights, are also sometimes used. Now, equipped with everything we've learned so far, let's go over a few clinical scenarios. Clinical scenario 1. A 6-year-old boy is sent from the emergency to the mental health clinic because the mother had reported that the boy had a seizure this morning. No investigations have been done, and the referral form showed a diagnosis of epilepsy. Upon taking further history, the mother reports that the child has never had seizures in the past. She states that the child has been having mild diarrhea and vomiting for the last 5 days. He has not been eating or drinking very well. However, his mother was very frightened by the seizure and is much more concerned about the seizure than the mild diarrhea and vomiting. And she asks you to give the child medication so he does not have seizures again. What will you do next in this scenario? If you decided to do a physical exam, then you have made the right choice. So you check the patient's vitals, and his pulse is 110 per minute, which is high. Blood pressure is 94/70, which is slightly low. He does not have a fever, but looks lethargic and is not very active. On inspection, his mouth and skin are dry and dehydrated, and his blood glucose is normal. So what do you think is going on? This child most likely has electrolyte abnormalities due to vomiting, diarrhea, and dehydration, possibly because of an infective gastroenteritis. This child and mother must be taken back to the emergency where the GP will order blood, urine, and stool tests to look for any abnormalities. He will need oral or IV hydration with electrolytes depending on the severity of the blood abnormalities. The electrolyte disturbance is what caused the seizure, and treating this underlying cause with fluids and salts is the life-saving measure here, and there is no need for anticonvulsant medication for his seizures. Clinical Scenario 2. A 21-year-old woman with past history of epilepsy on treatment with depakine and type 1 diabetes on daily insulin comes to the mental health clinic for epilepsy follow-up. In the middle of your conversation with her, she starts to sweat a lot and becomes confused and disoriented. She suddenly has a generalized tonic-clonic seizure in your clinic. The seizure lasts 2 minutes, but she is still very disoriented. What will you do next? The first step is to check her airway, breathing, and circulation to make sure she is breathing and conscious. Then, transport her to the emergency room immediately. Given that she is diabetic on insulin, first check blood glucose. Hypoglycemia is a very common cause for unconsciousness and seizure, even in a non-diabetic patient. If treated, it can be fatal. As in any case of active or recent seizure, the following must be done. After checking airway, breathing, and circulation, check vitals, including pulse, blood pressure, oxygen saturation, and temperature. Check blood glucose. Send blood tests immediately, and get a detailed history from a witness, caregiver, or from the patient if possible. The most important thing to note here is that even a patient with a history of epilepsy can have a seizure due to another underlying medical cause. Why do we, as mental health providers, need to know these causes? So we can appreciate that seizures and epilepsy are medical conditions and need to be managed appropriately. Although we, the mental health team, see epilepsy in the outpatient clinic and manage it on a regular basis, knowing the different medical conditions that could be potential precipitating factors can help us quickly identify and refer for treatment. It also helps us get a detailed and focused history, order appropriate investigations when needed, enables us to always consult with the medical team when there is active or recent seizures, and refer to a higher level of care whenever appropriate. This brings us to the end of Session 2. Murakoze Chane, and thank you for your attention.